Hi, everybody. Today's lecture or lectures, they're going to be quick, relatively painless, and we're going to talk about patient assessment. The middle lecture is going to be the longest one, or the middle section of the lecture. First part is about doing essentially what is a non-traditional sort of assessment. Okay, it's not necessarily an assessment of the patient; it's more the patient's living status. Okay, so think of it as getting to know your client. Okay, so in the context of furthering a paramedic skill set, community paramedicine, or something along those lines, this is what you're going to be doing. Okay, you've got to get as much backstory about your patient, about their living situation, their support network, what their environment is, and more than just looking at the environment from a is it safe for you to enter sort of perspective, is it safe for them to be in kind of perspective. Okay, so um, you've got to look at all of these different things that normally we just kind of take for granted. Okay, um, uh, doing their needs assessment, it gives you all of the information to get what their background situation is. Everything from their support network and family. Does anybody care about them? Does anybody care about them? Care enough about them to show up to help them? What is their healthcare status? Do they have a primary care physician? Um, are they compliant with medications and everything? And when you're assessing that patient and their individual needs, uh, do they need social services intervention? Right? Is it that kind of situation? So, like everything in EMS, a systematic approach would be best. Okay, but a systematic approach in this case is going to ensure that the person that we're trying to keep from falling through the cracks of the healthcare system does not fall through those cracks. Okay, if you take the time to do this correctly and make sure that your patients are um, basically assessed or their situation is assessed well and thoroughly, then that's not really a consideration. Okay, so when we are looking at our patient's needs assessment, okay, we're looking at everything. Um, we're looking at the family structures. We're looking at, uh, we're basically data collectors at this point, trying to figure out um, what is going to be the most positive outcome. How do we arrive at the most positive outcome for this patient's healthcare situation? Okay, so um, as we're doing this, you got to consider all of these aspects of the physical. Okay, so what kind of physical needs do they have? Are they living in an environment where if they're wheelchair bound, they have access to bathrooms and they can take care of themselves? Do they? Is there an issue with them reaching things at a height? Are they physically strong enough? Is there any sort of physical uh, deformity or infirmity that has happened to them? Any sort of physical problems like a stroke, and now they got a deficit? What are the psychological aspects of their condition and of them? Okay, if there are any. Now, um, with looking at that, not everybody that we run into is crazy, but some people do have psychological concerns. Okay, and if there is a diagnosis or a development of a condition, we would be in the place where we could do do that assessment to see if their emotional ability was out of control. If they were going from high to low, low to high with very little transition, you know, are we talking bipolar? If they're in a severe depressive state, um, are they situationally depressed? Is there a a potential manifestation of clinical depression given whatever their problems are? Looking at their social and financial concerns, do they have a support network at all? Is it friends? Is it family? Is it people from the church that they attend? Who cares about this person in the real world? and financial aspects. Are they, I hate to say well off enough, but are they financially stable enough where they don't have to worry about paying for the essentials, shelter, food, and medications? Or are they going to need some help? Okay, can they maintain their bills? Are they going to need some public assistance and go about potentially directing them in that way? Okay, so all of the things that we normally do as far as assessing a patient, okay, we do research a little bit. Okay, we want to know the backstory of why we were called. And now we're going to look at these patients. Um, we're going to go back and see what their health status has been. Okay, if it's a discharge at the hospital time, we're going to see what their treatment plan is and see what we can do to better facilitate that. We're going to interview the patient, obviously, and talk to them. And some of the things that you're going to need to know is what do they understand about their own condition? Yeah, because as everybody knows in EMS, some people don't know crap about their own body. Okay, and then we're going to do evaluations of the scene or their home, their living environment. We're going to do evaluations of the patient, find out, what is their norm, and those evaluations are more than just the physical state. Okay, the research, the first part of this, before you go. Okay, if the patient's enrolled in a community paramedic program, okay, what is the goal of that? It's to keep them from bouncing back to the hospital. It's making sure that their primary care physician and the physician that are over this community paramedic program are looking out for the patient's best interest and deciding what can be done to ensure that they don't fall through the cracks, if there aren't any issues with that patient post-discharge. Um, so we're going to look at medical condition. We're going to look at demographics. We're going to look at, a bit of their med history as far as what's gotten us here today. Okay. When we interview somebody, we do that all the time. Okay. In this case, it's just low pressure and low speed. Okay. You consider it a fact-finding mission. You're going to go in and ask lots of different questions. Okay. You're going to ask questions about everything. Okay. Not just the physical standing. You, you're going to have to interview this patient with a global or holistic view of their living situation. Um, Physical, psychological, financial, all of it. Okay. Now, with this, um, can they do? Okay. Can they do what they need to do for themselves? Okay. So their activities of daily life, their ADL. Um, can they do that on their own, or are they going to need help? Okay. Do they understand their medical condition, or do they need some education? Okay. Um, can they function without a helper? Can they eat by themselves if they have dysphagia, difficulty swallowing post-stroke? How's that going to change how they eat? If they have, you know, issues with mobility, how are they going to prepare meals? How are they going to wash themselves as far as basic hygiene needs? So, you know, what of their condition do they actually understand? Okay, again, cognitive functional needs of the patient, and if it's a little old person going back to another little old person that's trying to take care of them, well, what do both of them understand? Okay, not to get too simplistic, but um, again, patients don't understand if their family members who are the by default caregivers don't understand as well, then we're going to have some major problems that turn into 911 calls. So, and how can you best figure out whether they understand it? Have them explain it to you. Okay, you know, it's always presented, or I always present to students. If you really understand something, you can explain it to a small child. And if you can explain it to a small child in a way that they understand it, they can explain it back using their terms, and you get it. You get that they understand. So that's basically what we're doing with these people. Finding out what they know, filling in the gaps so that they can better understand what's going on with them. Okay? So I don't know if you've taken methodology, okay, but the learning style of the patient and caregiver, not everybody learns the same thing. Okay? No, I'm sorry, not everybody learns the same way is a more accurate way to put that. So you've got auditory, you've got visual, and you've got kinesthetic learners. Okay, so what I see, what I hear, what I can do. All right. So what is their learning style? Don't know. You don't know these people from Adam. So when you go out there and start doing this assessment, this is one of the things. How am I going to teach somebody? What is the best way to show them, to teach them, so that they take ownership of some information? If I don't try to figure out what their learning style is, I can't do it. Can't do it effectively. They won't learn it. They won't retain it. They won't be able to use it. Okay. So as we are looking at their access to social and financial resources, can they afford their medication? Can they afford food? Can they afford all of the things that it's going to take for them at their most comfortable living space, their home? Are they going to be able to do it? Okay. What kind of outreach services do we have available to them? Okay. And how do they reach out? Do they know numbers? Do they know people? Has there been a contact? Has there been a visit? All of the different things that it takes to set somebody up for success. Okay. Now, cultural values of the patient, caregiver, and family. Well, what does that have to do with anything? Okay, because not everybody has, the same perspective of healthcare as we do. So, if there is a cultural sensitivity or a cultural predisposition for doing things in a certain way, okay, we're going to have to walk our way through that and figure out, okay, given that, how do I accomplish this? Right? So, determining what the patient wants and how he or she perceives his or her current needs. Some people are delusional and they think they can get up and do on their own. They cook their meals for 50 years. They are not going to stop now. But they also have, the 30-second time span of memory. So they forget what they're doing. Okay, is that person more or less likely to burn the freaking house down when they're trying to cook a meal? Okay, and trying to get them to understand, you know, what is real versus what is wanted sometimes is extremely difficult. Okay, um, given what is possible, okay, and if they have a realistic expectation, okay, so what kind of things are we trying to change here? Getting them to have an honest assessment of their situation as is, and what kind of things are we able and willing to change. Okay? And then, in order to get somebody to do something, we typically have to get them to buy into it. So, how do you get somebody to buy into something? You let them in on the planning stage. Okay? You talk to them about, this is what I think might work, but if we had to get there, what are your thoughts? Okay, so at getting them, it's not just asking them how they want to do it, okay, but it's trying to get them kind of dialed into the fact that A, it needs to be done, and B, I'm willing to work with you and do things your way to a certain extent. Let's try and plan this together. Okay. Now, with the family support, um, well, let's go back one slide for a second. Okay. Um, First of all, we got to think about what is the living situation. Are they alone? Do they live with somebody like a full-time caregiver? Who's going to prep the medications? And does that person understand how to do that as those medications are prescribed? It's not just setting up a rattle box by color. It is taking Monday, Tuesday, Wednesday, the little box with the pills throughout the week and setting that up adequately, correctly to make sure that everything's good to go. If they have a PRN medication, okay, you understand when that is given, okay, whoever's giving it, who's going to make your meals, you know, um, who's your medical power of attorney if it's not you? Who's going to make those choices, decisions? Who's doing the grocery shopping? If you've got limited mobility or limited cognition, who's going to set you up for success? Um, is your patient realistic in what they determine what a success truly is given their condition? Okay. Now, you're not going to be able to wind the clock back and go back to uh, pre-event status, potentially, or pre-disease state, or surgery, or whatever their circumstance is. But, this last one about what they think is the best change and all that, and when we're trying to get them to buy into it, we have to realistically ask them, what are you going to consider a success? Because this is what the rest of us are looking at, and this is what we think might be successful. When it comes to the family support, um, we're used to kind of having to block out the family so that we can focus on the patient. And this sort of expanded scope for community paramedic, you can't do that. Okay, you've got to focus on the family dynamic. You've got to focus on the family as a whole. You've got to focus on if this gentleman is the patient, okay, and his wife and daughter are a caregiver, and this guy is the community medic who's going out and talking to people. He's going to want to know what all of these people bring to the table. Okay, what's his understanding and theirs? What's his capability and theirs? Who's going to be supportive of all the decisions that he's making? Who's ultimately decision maker, legality wise? How big of a role does the family unit itself um, play in all of the decisions that are made? Okay, and is this the extent of the family, or are there others that are going to have some buy-in as well? So, you ever childproof a house? Okay, if you're a parent, you probably have. Okay, if you're not a parent, you may not have. But if you've had, but if you've had a puppy or a kitten or something like that, and you try to make them a safe space where they can't screw anything up and they can't eat everything, you've done this. Okay, so all of that to say this: try granny proofing a house. Okay, try taking somebody with a sight deficit because of advancing diabetes and macular damage. Try setting up their uh, stove so that even if their vision is messed up and they're too proud to let too many people help them, they can not feel the eye to see if it's hot, but where the knobs or buttons or indicators are to turn up the heat or turn down the heat. Um, occupational therapy sometimes will super um, like sandpaper up there so that they can feel where what they're adjusting the heat to. Okay, um, but in our assessment of this sort of thing, let's just look at the house. Okay, do you have lamps? Do you have rugs? Okay, lamps have cords. That's a trip hazard. Rugs slip. That's a trip hazard. Are we talking stairs? If we're talking stairs, then we've got to consider that. Are there uneven surfaces going from one elevation, back in the 70s, having a two-step drop going into a living area? That was cool. Now it's where grandma's going to fall. So when we look at the home environment, we've got to do so with knowledge of what the patient's problems are, challenges, however you want to look at it, and how to best make that home environment one that is going to be successful for them. If we're looking at their workplace environment, okay, it's not just about prevention of accidents and falls, but it could be, okay, but it's also looking at things like air, okay, the air quality, or if they've got a pulmonary issue, or do they have a lot of flying components in the air? Is there a lot of particulate matter? That's going to be a challenge to somebody like that. So, um, access, again, uneven surfaces for trip and falls. You know, are there facilities available to them, both at the home or workplace, if they're still involved in work, that they can use? All right, I'm talking about bathrooms. I've been in some work areas where bathrooms are so small you could barely get through the door. Now you tell me how somebody who's temporarily or permanently in a wheelchair barely get through a door, and essentially what is a coat closet with a toilet in it. Okay, that's not going to be a workable thing for them. Getting them anywhere. Okay, the stairs are there a challenge? Walkways, are they compliant? Do they need a ramp going into or out of their home? We're looking at what their needs are. Okay, looking at transportation needs. Do they need a special van? Are they going to, you know, need to have some accommodations for transportation? And if they can't financially afford it, how do we engage those services? Okay, who do we call? What do we do? So, yeah, we're looking at this. Okay, stairs. Stairs are not a problem. I go up and down stairs all the time. Yeah, but I'm not, geriatric, and my stairs don't have loose things, loose runners that could easily displace if I'm shuffling my feet and all of a sudden I turn stairs into a slide. Okay, so we're looking at how this person is going to hurt themselves in this environment, and then we're trying to take that out. Okay, now when I say we are trying to take that out, I mean we as a healthcare team and a family team. It's not like you can just start grabbing rugs and taking lamps out. No, okay, but you can tell them what the dangers are. You can say this is what needs to happen, and this is kind of what we need to do. All right. Well, what about other things? How about smoke detectors? Okay, if you have somebody with a hearing deficit, do you think you're going to need a different type of smoke detector potentially? One that not only has the auditory component, but maybe has the flashing light so that it gets their attention more readily. Okay, so again, looking at what their needs are and looking at how best to set them up for success. Looking at this environment, okay, if you get somebody with limited mobility, well, it seems like these are wide open aisles in this photo, so that's probably good, right? Okay, but what kind of environment is it if they have a pulmonary pathology? Okay, no matter what kind of warehouse you're in, you're likely to have a lot of dust and dirt, and it's going to be hot, and there's going to be a lot of different things. What about the surface of the floor? If you've got spills, if you've got powders or anything else, these things are typically slick. So if there's a fall potential, have to be cognizant of that and see what we can do to mitigate those circumstances. It's all about risk mitigation when we're doing patient needs assessments. Okay. Now, if they don't have access to transport, like I said, it's something that we're going to troubleshoot, and we're going to have to look at the car. We're going to have to look at the vehicle that they're going in, just to see, is this going to work for them given where we are now. Okay. Now, goals within the community paramedic or advanced paramedic or, whatever name du jour that they put on it in a couple of years, you're basically the physician extender. Okay, you're going out and working with the mobile integrated health care team and trying to do the best for the patient. Again, just trying to make sure that people's needs are being met without inundating an already taxed healthcare system. Okay? So when you have a bunch of things, okay, prioritize. What's the most important? Go with the top three. Um, Engage the family, engage the patient, and collaborate with them. Even if it's your idea, if you can sell the idea that it was theirs, they're more likely to agree with it and go with it and follow it. But if you just walk in and you need to do A, B, and C, then that sounds like you're telling me, a grown individual, what I need to be doing, and you are not my mom or dad, and I'm not a child, so you can kind of stop that pretty quick. So if you're quite the salesperson, you can buy into it. Now, with the other services that they might need, okay, determine what those are. Get the backstory and get the extent of the issue. Okay, make sure that we know all that we need to know. Okay, for these outreach services, do they really need somebody coming in to help them with washing, okay, themselves? Do they need an NA? If they can't afford an NA, what can we do? Okay, Medicare, Medicaid, I mean, services are available. It's just about getting them to the people that need them and not, set them up for abuse of that system as well. Okay? So it's all about assessment and supportive cheerleader, rah rah sort of things, but it's about being relying on the things that EMS has taught you, assessment needs. Okay, now we're just expanding that assessment. It's not just about physical assessment; it's about their needs as an individual. Now, when we look at what these outreach services could be, how about um, who can help my patient with these different things? Okay, preventative primary care services. Okay, so let's see what kind of physicians can follow up all this condition. Um, let's see um, if things happen where this person is going to seek some sort of care. Okay, school health services, you don't really think about that a lot, but what if you have someone who has a child in school, and now, because we're trying to be holistic in our approach, we also have to think about the family needs. Okay, not just the adult patient, but the juveniles that live with that person. Physicians, clinics, parish nursing, okay, volunteer agencies. If they can't have a ramp built, there are volunteer agencies that can, facilitate that need. But reaching out to them, you know, Meals on Wheels, because they can't cook for themselves. You got to reach out to them. You have to avail that person to that service. They have to know about it, and facilitating that, you know, something that you can do for them. Looking at their uh, hospitalizations, wow, what kind of hospitals that they may have to go to, if they are going to need or if they should need any sort of rehabilitation services, occupational therapy, speech therapy, physical therapy, all of those different things. Um, some things that uh, you don't necessarily take into account, but those full-time caregivers, okay, um, sometimes those folks get overwhelmed, and what happens then? Okay, if you look at statistics, you'll have a greater chance of elder abuse and problems with the patient overall. So extended care facilities and respite care, if that family needs to go on a vacation and grandma and her condition is preventing that, then what about respite care? What about daycare centers, either for the child or for adult daycare, if that person needs to take care of other pressing issues? If you haven't seen it, it's because you're too young. But if you're taking care of an adult parent who has cognitive decline or physical problems, it gets overwhelming quick. Okay, and if it gets overwhelming, how do you get out of that? You can't just take a day off caring about it. So um, having some respite care so that you can take a deep breath and know that mom or dad or whomever is being taken care of. So anyway, when we're looking at some of these special considerations for our patients, okay, we kind of take for granted that we're going to be able to assess that house or their housing status. Well, what if there is no housing status because they're homeless? And their special needs. What if they have cognitive deficit? Okay, they're not um, mentally retarded to they need to be institutionalized aspect, but they just have an overall low IQ. They're going to have some special needs. Um, age, their medical literacy, they don't know what's wrong with themselves. They don't know their body. Okay, how are you going to follow up with a patient that's homeless? Really? I mean, how are you going to kind of interact with them? So, becoming very simplistic, we're going to look at the big overall needs, getting them shelter, giving them access to shelter somewhere by some means, trying to find a place for them to have it, to live, um, so that you can then follow up with their care and focus on them working on themselves. Okay. What about somebody on the spectrum? Everybody knows that autism is a thing, and there is an ASD, the autism spectrum disorder. Not everybody who has autism is profoundly affected, but some are. So, what are their issues? Okay, because autism is this complex neurological issue. You probably know somebody who's on the spectrum if you yourself aren't. I mean, depending on how broad that spectrum is, we all could be on it in certain aspects. Okay, but who's going to know these people best? The people that are around them the most. So when you are trying to take care of these folks, um, the caregiver is going to be your best guide as to what their unique challenges are, okay, and how you are providing help to them is also going to be a challenge, okay. If there are established local protocols, um, then that would be a good thing for us to follow. But remember that everything varies so widely in autism that uh, each situation is kind of unique. Now, somebody with physical disabilities, um, you know, physical ability in patients can be reduced by age, injury, or illness. Okay, so let's figure out what those physical disabilities are and the best way to mitigate those. Um, and figuring out how to limit that, how to best manage that, how to get that person empowered and active enough to help with their own issues. Um, looking at this, guarantee you that ramp hasn't always been on this house, but if you have a patient who's now having to use a walker, okay, that might be a thing to put in there. A wheelchair, definitely. A walker, maybe. Why? If they're of advanced age and they can't manipulate, well, that's just an increased mode for them to fall. Okay? So, modifying their existing area and their house, their living environment. With dementia is a absolute horrendous thing to watch somebody lose themselves. Okay. Now, with that, not only is it tough on the patient who, at some various stages of dementia development, they realize something's going on, but it's also extremely difficult for those around them because they are confronted with it even when the patient is oblivious to it. Okay. So we become emotional support for those people that are trying to help their family members. Okay. So respite care programs to provide high quality day or temporary care and give caregivers a break. There are various charities in North Carolina that will, you know what, if you want to take a break and go on vacation with your family, take a long weekend, do something for your kids, and your mom has dementia, I forget the exact name of it, but it's something like Dementia Alliance or something, anyway, here in North Carolina. But my wife has used that because her sibling is in Florida, her mom is here, and she has advancing dementia. And taking care of her while this cognitive decline, this slow rolling train wreck, it's been all encompassing for years. Okay, so when it comes to age, precautions, adjustments to home environment to ensure safety and reduce risk of accidents, performing patient needs assessment. Remember, do not make assumptions, plan longer visits, speak clearly and directly. Make sure that you can communicate with your advanced age patients, the ones that might be a little hard of hearing, the ones that are just faking it and they smile at you and nod and they haven't heard very much of what you said. Okay? Don't make assumptions as, you know, to have ageism and age discrimination against people, but, you know, get to know your people. Sit down, take your time, and kind of be wide open and yet judgmental at the same time. I know it sounds weird, but wide open as in you are noticing everything from the environment, the interaction, the family interaction, the whole 9 yards, and judge what you think is going on. The patient says they can't hear, but you notice that the volume's always on 50 at least. But when somebody comes in, they turn it down. You know, just little things. So anyway, medical literacy. Um, don't talk above your patient's head. Um, use verbiage that they're used to using. Okay, not everybody is an insulin dependent diabetic. Some people have the sugar and they got to take shots. Okay, so you know the drill. Communicate on their level so that they take it. Again, if you can explain it to a child and that child can explain it back to you using their words, and then both of you understand that that person knows what they're talking about. Okay, and we do that with our interview process and gaining information about our patient. When we figure something out, okay, we need to act on it. There is no clearer setting than that than this case, abuse and neglect. Okay, we should be essentially visiting these people often enough so that if something were going on, then we could intervene and get social services, law enforcement, whoever needs to be involved. Now, if even if you just suspect, okay, that is going on, and you've got no hard evidence, does that really matter? No. Okay. If you suspect it and you turn it in and it becomes a thing, what's the worst that happens? You're wrong. Okay. And as long as you document that sort of thing, you're erring on the side of caution in the interest, you're being a patient advocate. Okay? Now, are the family members going to love you for it? No. Caregivers going to love you for it? No. I mean, you turn them in for potentially beating on grandma. So they're not going to be happy, but your patient was taken care of and you always have justification to do what you're doing. So be cautious. Be alert to the signs and symptoms of it. Okay? Unusual bruising, non-specific complaints, history of depression, attempted suicide. Now, abuse, all abuse is not physical. What about emotional abuse? What about financial abuse? Yes, financial abuse. You have to really have your antenna up when you're doing this sort of interview and gaining this kind of information. That history of depression and attempted suicide, oh, why? Why would that be a thing? Well, if the person feels like nobody on the face of the planet loves them, including the people that are taking care of them, that's going to be a problem. And there's one way out, potentially, to say. So, how do you know it's abuse or neglect? Well, look at your patient, analyze. Okay, inappropriate clothing. They're always in the bed. They're always wearing a diaper. When they are clothed, they're habitually wearing the same clothing. Poor hygiene. Poor hygiene. That smell, that musty, old, sweaty. Yeah, you know what I'm talking about. That smells like old people funk. Um, Sorry, but of that poor hygiene, why is it that way? Is it because their daily needs aren't being met? Do they want to shower, but they're afraid to step into the tub? Or there are places, some living conditions where that tub can be converted into a walk-in shower with a shower chair. Okay, so if that poor hygiene is a lack of availability, then that's something that you should pick up as well. If they're unable to do their own ADLs and because of deficits, if somebody's not taking care of them, that is neglect. Okay, untreated medical issues, decubitus ulcers. That's not just that's not the only one, obviously. But what about recurrent UTIs or upper respiratory infections? Um, Recurrent bouts of pneumonia. Why? Okay. Sad but true. Grandma wants to go home and be with her dogs, and now she can't take care of her dogs, and nobody's taking care of her, so she can't take care of the dogs, and they can't take care of the dogs because there's no day. What happens to the dogs? Poor old turds. They slowly become neglected as well. Okay, looking at that sort of thing. Again, it's a holistic look at the patient's living environment, living conditions. Last, the spoiled food part. It's great for Meals on Wheels to take out meals for people, but if they're not eating it, what's going to happen to that food? It's going to sit there and it's going to rot. So things like that will tell you that your patient's not having their daily needs met and not having nutritional intake. Their caloric intake is bad, and overall their state of health is going to decline. So the discovery method, useful technique for teaching patients problem solving skills. So let's play a what if game. What would you do if you had to do this? Okay. How would who would you call if you needed something? Um, plan 50 questions. Okay. Now, if you're talking to a caregiver, okay, if this were to happen, what would you do? Whether they're technologically aided patients or, whatever the circumstance is. Who would you call? What would you do? What would your contact? Basically, your flow chart be. Um, just making sure that in the event of something happening, they have some sort of knowledge. And some people will take a lot of notes, and some people won't. They'll try to remember it all, but at least they've heard it and you've talked about it. With the patient drawing from past experience and existing knowledge to discover facts, relationships, and new concepts. So, what does all of this sum total mean to you? That it's not just um, patient interviews, as in assessment in the prototypical way. Okay, now it is looking at their living conditions. Okay, so the next section is all about patient assessment, and this is going to be a little bit quicker because it's basically building on what is a normal assessment. Okay, so the importance of assessment, how to deal with assessment techniques. Okay, now with this, I'm going to hit on a few things that lots of people kind of miss. Okay, this person's obviously listening to what? Respiratory sounds. All right, cool. If you're doing your patient assessment, that should be a good thing that you do all the time. Okay, your patient exam always has to be good and thorough, but the subjective versus objective. Okay, symptoms and signs. Symptoms are what they complain of, and objective data or signs are what you see or can detect. Now, your assessment, starting from really important to less important, have time in mind. Okay, your patient assessment, if you're going to do an expanded scope, it's not as time sensitive. So all those things that your instructor may have told you, you're never going to do this in the field. You're not going to have to do this. Okay, it's mentioned in the book, but all those precursors to giving you a little bit of information that you may have forgotten. Well, now you got time. Okay, if you have an expanded scope, if you have a different role, now you got time. Okay, it's all built on your assessment, your patient interview, gathering information. Okay, so general information, history of chief complaint, all that stuff, PMH, and family medical history. Most of the time, the family medical history is kind of left out of the loop sometimes, and the only time that that's really brought back is, if somebody were to have like chest pains when they're in their 30s. Okay, not really relevant. We're not really thinking high cardiac potential unless they've got history of previous cardiac problems for potentially resulting from infancy and cardiac deformity and all that sort of thing, or they've had bad habits, some pathomimetics, as in they've done a lot of coke damage, or how about the fact that their mom or dad, first or second generation family member, had a fatal cardiac event in their 40s. Well, now it's relevant. Okay, so looking at family medical history. Okay, and something for you to think of. What do you do if the patient's adopted? No, I'll wait. No, I'm not going to wait. What are you going to do if the patient's family, if the family member is adopted? Well, you can't really go off their family history. Okay, so if that family medical history sometimes is given during the adoption process, okay, so that you have a better genealogical sort of look at what kind of problems they might be predisposed to later in life. Okay, social history, medications and allergies, general assessment, vital signs, review assessments. Now, all of that is stuff that we know. Okay, so if we're going to do this and have a greater depth of assessment, okay, I'm not going to pretend that I know more about assessment than anybody listening or looking at this. Okay, um, I'm not going to do it, even though I've been in EMS for a number of years, and even though I've taught this for a number of years and have the degrees in it. Doesn't really matter. There's always somebody that can do it better or has a different interview technique or a different assessment technique that might be a little bit better than what I've gained or held on to for all these years. Okay. But there are a couple of things that you need to think about, and maybe I can give you a little bit, okay, as far as finer points. So, as you're interviewing your patient, do so with a purpose. Yeah, your general demographic info, take all things into account. Their chief complaint. All right, now let's get the backstory. All the while, head and hand and working simultaneously. Your brain's working, your mouth is working, your ears are working, your hands are working, doing your job, and you have a purpose for every question. Even if it's because right now you don't know what's going on, you have a purpose for that next question, and you have a purpose for the follow-up question, and you're trying to take information that could be possibilities down to probabilities down to a differential diagnosis and something for you to work with. Okay, so their PMH. Um, what kind of problems that they had now, maybe that has influenced what's going on today. Okay, if you have the ability, okay, with their past medical history, lab values, any sort of cardiac or any other findings, disease process. I mean, you can get some of that just by looking at the medications. Again, not the stuff that is going to surprise you. Everybody knows this, but having a good resource or being able to look at some of those medications that are being developed all the time and finding out what this patient has been prescribed for. All right, it's great, but what if they're being prescribed off-label usage? Okay, like what are you talking about, Billy? Well, you know, beta blockers. We think of those in a certain context, but they can also be used for migraines. So why is this person being prescribed that? Not everything is going to be so transparent. So it would be great if we had everybody's electronic health record. That would be great. But if we don't, and we're not part of the mobile integrated healthcare team, and I'm not assuming that for this lecture, then we can't look at their past charts. Okay, we can look around for medical devices. We can ask about past medical history, surgical interventions, et cetera, and we can do the point of care testing that we have available to us. But right now, in most EMS agencies, that's kind of limited. Okay, now if you get an ISTAT is great. Okay, but again, it has its limitations. Okay, it's definitely not necessarily going to speed up your care. Okay, because you got to draw blood, you got to apply that, you got to wait for results and that sort of thing, and you know, depending on what you're testing for, you can look at a couple of minutes up to half an hour. Okay, you're not likely to be waiting for those half an hour results before you pick a pathway and go. All right, but just saying, point of care testing is great, but it's not going to solve all of our problems. I mean, if you look at a fast exam with ultrasound, that's point of care testing, so to speak. We're not getting a blood sample to do the testing, but we are doing something that is going to have us essentially pulling back the veil, looking into the body and the status. When we're looking at things like pulmonary function testing, when the last time you really thought about peak expiratory flow? Okay. Only after you've had surgery, when they have you keeping the ball up and keeping him in between there so that pneumonia doesn't set in if you're bed bound for a little while. That's the only time that people really think about that sort of thing, usually. But now, you know, when you go to this person again and again, potentially, These are things that you might have to worry about, because if they're not exercising their lungs, and you know the big healthcare system wants to treat and treat and get them out of the hospital into their own environment where they can rehab there, well, if they don't have respiratory coming by and making them do this sort of stuff, well, what's going to happen to them? Okay, so anyway, you know how to be professional, so I'm not going to go through that. Okay, you know what works and what doesn't when it comes to communication. If you haven't figured that out by now, God help you. All right, but there is a right and a wrong way to communicate with people. Okay, there is a professional way to communicate with people, and as much as you have people that jump up and down until they're blue in the face and scream and holler about calling people darling or false or sweetheart or things like that. You always have to read your audience, and what works, works. And if they don't see it as a derogatory thing, if they don't see it as an insult, if they see it as a alternative endearment, and they know that, they have in their mind that you care about them and all of that stuff, who cares? Okay, it's not necessarily unprofessional if it's professionally done and it's productive. Okay, so know how to communicate with the people that you need to communicate with. Everybody knows what to do and what not to do. This is what not to do. Okay, this guy does not care, and that is readily apparent to the patient who has now got a closed posture. Both of them have a closed posture. If you look off, if you roll your eyes, if you have that teenage girl thing that my daughter has, where she big heavy sighs and rolling their eyes every 2 to 3 seconds, oh my dear baby Jesus, don't do it. But you know that. Okay, knowing how to ask questions, you know this. Start with open-ended and then start, kind of catering it to what you need. The problem with open-ended questions is it gives them an open end that they can expound on whatever for a long, long time. Okay, now it does allow for the most information, but it is a time-consuming thing. So know when to rein them back in. You rein them in with closed-ended questions so that they're not just rambling and talking on forever like I am now. You're getting them back to the point. Okay. Um, everybody, I would like to think that everybody knows how to deal with these type patients. All right, the ones that are silent. Okay. Why are they silent? Is it a cognitive issue? Is it a speech issue as far as the inability to speak and to respond back to you? Is there a deficit there? Okay. If somebody's overly talkative, is that a psychological condition? Is that a sympathetic stimulant that they have? They are wound up. Are they cracked up or what? Angry or hostile patients, hopefully you know how to deal with those. Okay. Confusing behavior or history. Well, everybody gets confused. I'm going to take for granted that you know how to deal with some of those situations. All of these are challenges. Okay, the biggest challenge you might find is language barrier. But now, guess what? You've got this magical little device in your pocket that if you download the right app, that's not a barrier to communication anymore. You speak into the phone, and all of a sudden the phone speaks to them, and hopefully nothing is lost in translation. Okay, sensory losses, limited vision, hearing, speech disorders, articulation disorders. Um, there's a way to overcome those things, and I'm sure that was gone over in paramedic school for you. Okay, so again, going to fly through this. General info, you know what to get. Okay, chief complaint, you know how to get that, and hopefully you're doing it the right way. OPQRST Aspen. Okay, if you're not familiar with the Aspen part, because some students were available to that, that's associated symptoms and program negatives. Okay, so chest pain. Okay, we used to the OPQRST Aspen associated symptoms. Do you have nausea and vomiting? Do you have respiratory distress along with that, you know, with the R, and does it radiate up and over? Okay, well, that would be the associated symptoms. Okay, nausea and vomiting to coincide with the chest pain, associated symptoms. They're sweating, okay, just sweating bullets, that's some associated symptoms. If they don't have any of those things, though, that would be pertinent negatives. Now, it doesn't definitively say yes or no to anything, but it's another puzzle piece to lead you in a direction. Right? Their medical history. Okay, so going through their medical history, what's relevant and what's not. Okay, depending on what your patient's complaint is, what their presentation is, childhood illnesses may or may not really ever be covered by your interview, nor should it. Okay, but if you have, let's say, an 80-year-old and they have a murmur, and they ordinarily don't have a murmur, could this go back to the childhood bout of rheumatic fever? Yes, it could. Okay, are you going to be the one to, you know, finally get that puzzle piece together? Maybe not. So sometimes it's relevant, sometimes it's not, but you do typically try to hit all of these things. And the psychiatric history, okay? Lots of times people avoid asking about psych history. Don't, okay? Now, if a family member says, yeah, it's been crazy for years, that's not a psychiatric history, that's an opinion. Psychiatric history is diagnosed condition, clinician, perhaps prescribed medications, and compliance or non-compliance with said medication. Okay, family med history, we're looking for maybe 1-2 generations. Okay, 1-2 branches down the tree. So mother, father, sister, brother, grandparents, sort of looking like that. Okay, with that, we normally see the manifestation within the general the generational approach to what the familial medical history is. Social history, again, we talked about that. Social clubs, groups, family support. Who cares if you live or die? Okay, not. Who cares if you're sick? Who's going to help? Is there anyone there? Because if not, what do you have? You have a lot of isolation. You have a lot of you know, psychological components to that. Okay? Meds and allergies, know how to do that. Conducting the physical exam. Okay, again, bits and pieces of this maybe delving into. Using a systematic approach. Okay, first of all, you got to set the stage, and I'm going to keep kind of going back to a exam room in a doctor's office. Okay, most of those are not private, warm, and well lit. It's been my experience that they got the lighted part usually. They are private. I mean, there's a door that they can close. But warm, they are not. But these people were assessing in their homes. So let's do that. Here's a couple of pieces of equipment, one you have and one you don't, typically on an ambulance, but that reflex hammer, you can use that stethoscope in place of that reflex hammer and elicit the same DTRs, D10 reflexes. So it doesn't really matter. Okay. Everybody has a stethoscope these days. If you know how to use it, that would be great. Okay. Eye charts. Most of the time, we don't have that. Okay. Now, could we get them to focus on something, read something? Yeah, it might be kind of important to that. But having an assessment card or something pre-made like this, no, we don't. Okay. 12 leads, everybody's got one. Portable oximeter, yeah, everybody's got one. Cat mode, yeah, everybody's got that. Okay, so these are just kind of givens. And on most patient encounters, you're going to use most, if not all of that. Okay, now this building patient rapport, privacy, and setting expectations, okay, hasn't really changed from paramedic school. Role and importance of a physical exam, it hasn't changed. without that physical exam, you can't really treat what you haven't assessed. Okay, lots of you have commented about assessment and the discussion board. Okay, and I agree with a lot of what you're saying. Um, Assessments taught pretty effectively in paramedic school, but how diligent are you hanging on to that throughout your paramedic practice? That's where the problem is. If you become complacent / lazy and you don't do good patient assessments, you're going to miss pieces and you're going to wind up mistreating patients perhaps. Okay? You know the full examination techniques, you're not going to beat that. So some things that with an expanded scope, if you are assisting a physician, okay, if you are working in some sort of hospital function, it may be a lot of functional task orientation now when it comes to paramedics inside a hospital. But you've got to look with your eye toward the future where we're really good at assessment. Okay, so looking at somebody's body and their complaint is not emergent or life-threatening. Well, what if you're working sooner or later in some sort of clinic setting and they want to come in and they want to say, yeah, I've got this rash, I've got this thing, what do you think that is? Okay, so our inspection, okay, is not just about the typical, but think about the things that are going to expand with that. Okay, yeah, you can tell that there's a rash there. What kind? Okay, when you are inspecting somebody, okay, do you read their affect, how their facial expressions change or not? Okay, their ambulatory motion, their moving of pieces and parts. Is there any sort of ataxia? Looking if there's any sort of cogwheel rigidity. All of the different things that you can assess. Are you assessing? Okay. You going home at the end of your shift may kind of depend on what this patient's facial expression, their mood and behavior is, and that's something that we're getting throughout our interaction with them because we know what we're doing. That's assuming that you know what you're doing. Palpation, laying hands on somebody, that's easy. Okay, but again, superficial versus deep palpation, depending on what their complaint is, maybe we do that. I mean, lots of things in a paramedic manual, okay, an advanced patient assessment book, okay. If let me pull some up here, okay. Now, I don't know. I did not require this book. I do for EMS advanced patient assessment, okay. But the Bates Pocket Guide to Physical Examination History Taking. Okay, it's like 30, 40 bucks, something like that. And I'm not getting paid by the manufacturer to tell you this. But this thing that can fit in, a cargo pant pocket, uh, is excellent when it comes to a lot of the physical exam techniques. And it takes it beyond what a typical paramedic is going to use. Okay. First introduced to that when I was going through the Western Carolina program, fell in love with patient assessment, try to teach a little bit of expansion on the typical ever since. Now, we take for granted that palpation is palpation. No, it's not. It depends on what you're trying to figure out. Okay, are you trying to figure out if there is um, organ dysfunction, if there is something wrong with the muscular layer that's overlying, if you're trying to figure out if there's muscle rigidity, or we're trying to look for pulsating masses in the abdomen. It all kind of depends on what your issue is. And then you've got to have knowledge of anatomy to know if I want to find a liver border and see if this person has a fatty liver or one that is enlarged, they got a hepatomegaly. Where exactly on that right of the quad am I going to feel that? And how much pressure do I need? And if I think there's a problem and I hook my fingers underneath their rib cage and have them take a deep breath, and they have pain and increased sensitivity, what does that trigger me? Maybe you were taught some of this stuff in paramedic school, maybe none of this sounds familiar. Okay, percussion. We don't do a whole lot of percussion. Okay, but why is that? Because usually in noisy environments. Okay, but when you are tapping on a patient body part, you can typically elicit a little bit of sound difference. Okay, and you can tell, is that chest filled with air outside where it should be, pneumothorax? Is it filled with fluid? Okay, blood outside where that should be, hemothorax, combination of the two. Okay, and you got to take all of those things, but you can also do depression of the abdomen. When it comes down to it, there's nothing wrong with this advance or this thing that we should be doing, but most of the time the environment, it's not that good for us to do it. But now you're in a clinic setting. Now you're in a patient's house. Now you're in a patient's house, and you're not rushed because you got a different scope of practice. Okay, you got a different approach. It doesn't have to be so time sensitive that you can't go in and do that. We're going to be talking about telehealth, and if you had to report whether this person had issues, okay, whether it's collection of fluid, collection of air, whatever, if you don't have advanced diagnostic tools, then all you can do is go buy some of these things that were broached on in paramedic school. Okay, so why is this person tapping back here on the back? Okay, sound transmission. Okay, if we are putting our fingers in there to act as a go-between, we're still transferring vibration. Okay, so direct percussion is not having your fingers in the way, and indirect is this technique down at the bottom. Okay, now auscultation, it's only as good as the person that's doing it. Let's be honest. If you got a crappy stethoscope, if you don't know where to place the head of the stethoscope, then you telling me what breath sounds are is meaningless. If I ask you about heart tones and you don't know where to listen or what you're listening for, it's meaningless. Okay? So if you don't know how to auscultate breath sounds, vowel sounds, heart tones, you probably should up your game a little bit. Okay? So customizing your physical exam, what do they need to have that exam on? Okay? Why are you there? What is your goal? Why are you doing it? So it's still looking at the same thing. Okay, your general assessment, disease, disabilities, poor health. Well, what would indicate these things to you? Well, it depends. Okay, disease states can be gained from your review of the patient condition before you went out there, the discharge notes, whatever, their chart, disabilities demonstrated or assessed. Okay, their poor state of health. How do you know that they have a poor state of health? Well, you look at them. Okay, now, as all of this stuff really hasn't changed, I'm just going to be flipping through here. Okay, how do you know somebody's weight is good? Okay, everybody points it out to the height weight chart usually. You know, I'm obese. Well, it goes back to BMI. Okay, everybody has an ideal weight for their height, but is that everybody's ideal weight? No. Let's be honest. But how does the patient feel about their weight? Sometimes that's a good question to ask. Okay, I'm not going to insult your intelligence with pulse respirations and blood pressure. Hopefully, you can take a good blood pressure and you're not bound by the auto BP cuffs. Okay, but knowing how to use the good old-fashioned manual blood pressure cuff, that's a skill set. And unfortunately, I think that skill set is dying. Okay? When technology breaks down, you're still left with tools, if you can use it. Okay, temperature. Okay, so depending on where you are, what kind of thermometer you're using, and how effective you are at taking the temperature, you can get good or completely unreliable results. If you don't aim this at the tympanic membrane, okay, this tympanic thermometer, you're getting the internal temperature of tissue directly inside the ear opening, and that means absolutely jack crap on a cold day. So if somebody's mouth breathing and you take an oral temperature, you can't throw out common sense when it comes to doing this stuff. Okay, pulse oximetry, you know the pros and cons of that. It tells you bound hemoglobin, but bound by what? Some don't get all of that. They don't get bogged down with details. It's just bound hemoglobin. And carbon monoxide, cyanide binds hemoglobin as well. Height and weight. If you're doing a long-term like clinic follow-up or an expanded scope of practice, knowing big shifts in the weight, they're gaining a heck of a lot of weight or they're losing a heck of a lot of weight, that's going to mean something. Okay, so and the next question is why? Okay, could be a disease process. Review of systems. Okay, we're good with all of these things. Okay, we're better at others. Okay, the skin assessment. We go with are they pale, cool, clammy, diaphoretic? We're looking for things. Turgor, okay, well, they're dehydrated. All right, cool. But what about this? What does this mean? Okay, depending on whether you have TKI, purpura, macular vesicles, can tell you whether this is, viral in nature. Have they come in contact with, some little mite bug or everybody's favorite bed bugs and stuff like that. Is this sepsis? Okay? Is this skin breakdown because of improper hygiene, and that's opened the door, and now they're just getting, is this an outbreak of disease or manifestation of disease? So all of those things, depending on what you see, how is it raised, is it indurated, is um, you know not just the look, but the size. Okay, there's the big spots and the little spots, or the raised spots. All of those different things can mean different things for your patient. Even the way that a rash presents. Okay, what you're looking at here is the butterfly rash. Okay, or the malar rash. And if you're unfamiliar with what that means, okay, imagine somebody that had the wings of a butterfly that's going down their cheeks, up on their nose, and to their forehead just a little bit. Okay, and you're looking at lupus. Okay, if somebody has, the tip end of their nose that has a lot of red and broken blood vessels, well, what does that tell you about your assessment? Well, you're probably looking at somebody who's had an alcohol history, an alcohol problem. Okay. Head, eyes, ears, nose, and throat. If you know and have all of the equipment that's necessary to do that, I mean, you can tell a lot, but it's limited. Okay. When you look at physical round reactive to light using an otoscope, an ophthalmoscope, the eyes and the ears can tell you a bit. Okay, you can see if there's any sort of congestion into the blood flow in the back of the eye. You can tell if there's any sort of occlusion of blood flow. You can see if the borders are right and regular the way that they should be. Looking directly face to face with somebody, it's going to be difficult, but that's why you see in the bottom over here is off to an angle so that you can look in there. Okay, again, not going to insult your intelligence about how to do some of this stuff. Finer points, if you ever have one of these in your hand, okay, and you're going to use an otoscope, Notice the clinician's hand placement, okay? Pulling up on the ear, okay, the external portion of it, okay? And then they have their hand in between the otoscope and the patient's head, okay? Not everybody likes things going in their ear, and when you put that in their ear, what if they move their head really quick? Well, with that hand, it's going to prevent the otoscope from going in further and potentially causing damage. So you do that with adults and peds. In case you've never had to use one, that's why they hold it the way they do. Okay? So the last time we looked up somebody's nose, we were probably looking for a foreign body in a kid, and they shoved a bean or a rock up there. But what other information can you get by looking up there? Well, does this patient like to, I don't know, snort a bunch of stuff? Bleeding, discharge, obstructions, foreign bodies. Yeah, we can get all that. All right. Again, not going to insult your intelligence. You know when you're looking at the throat, what you're looking for. But I will say, this blue section right here, and this blue section right here, and this, that is mostly looking for airway issues. If we've got airway breach on the trach, okay, what's going to happen here? Okay, if we got airway breach, we've got a leak, we're going to have air accumulate underneath the skin. So if we've got increased work of breathing, where are we going to see it? We're going to see these muscles, we're going to see these muscles, we're going to see them all engage. And, you know, when you're looking at respiratory distress, respiratory compromise, tracheal shifting, tracheal tugging, if we're looking at JVD, all of the things that we can ascertain from the neck, it's fairly important, right? Cardiorespiratory assessment, don't think of it as just the heart and lungs, okay? As you see here, we're looking at bony deformity as well, and not just is it broke, the typical thing. No, we're looking for scoliosis and kyphosis. So we're looking for what? We're looking for the symmetry of the body, and we're looking for anything that seems odd. And if they have an unnatural curve, okay? If you're unfamiliar with the term kyphosis or kyphotic hump or lordosis, scoliosis, all that's terminology. And, you know, kyphosis is grandma hump. Okay, lordosis is a sway back. It's a great big divot so that this person's butt sticks out really far. And scoliosis, this is not in line on the vertical plane. There's a shift. Okay, and if you think back to when you were a kid, you know scoliosis is something less than a straight back. How do they test you for that? They have you bend over. Okay, and then you run your hand along their spinal column to see if there's any variance to one side or the other. Okay, if you're not familiar with tactile fremitus, that's again, you're looking at how sound is being transmitted through tissue. Okay, and tissue being lung, and tissue being congested or not congested, and pneumonia or not. Okay, as much as we like to auscultate, sometimes, you know, tapping is going to play a role as well. If you've ever had them do that to you, that's what they were doing. Okay. With this, let's see. What's this guy doing? Okay. Looking for vibration. Why would things like this be vibrating? Okay. Why? Well, what are we trying to get here? Okay. And what if there's some sort of vibratory sensation there? What would that mean? What about in the presence of the patient having chest pain? Could it be that they have an inflammatory response and pericarditis? Okay. So anyway, uh, when we auscultate the heart cells, okay, make sure that you know what intercostal space that you're listening for, and what you're likely to hear. Okay. If you're not that good with um, murmurs and that sort of thing, there are a lot of resources online that you should probably listen to. Okay. Now, if you know where to place your stethoscope, and you know it's not just about Tennessee or Kentucky, okay? How harsh are the murmurs? Is it, what phase of the cardiac event are you hearing that in? Okay, is it filling? Is it pumping? Is it a bridge between the two? Um, when it comes down to it, big murmurs, you don't hear a hell of a lot of sound, because if you're thinking of like ventricular defect in a kid, if you were listening for a murmur and they had VSD, but it was a great big hole, it's going to be an easy transition from left to right side, and so you have that left to right shunt, and because it's a big hole, it's not that loud. The smaller murmurs are going to make more noise, right? Because there's more resistance. If you've never listened to Bruy, okay, or Brutes, depending on who taught you, again, you hear a thrill. It's a turbulent blood flow. When you're looking for JVD, okay, we think of JVD as in it's easier measured at an angle, okay, and if you've never had to do this, okay, ascites or a fluid wave, poke this guy over here on the side, have a little bit of pressure right here at midline, and see if, like an old sort of waterbed, you've got a rush of fluid, okay? So as you poke the side of them, okay, for lack of a better term, you shift that fluid, okay? If they're mismanaging fluid, you're going to feel like a wave come over here and hit your hand. Right? When you're looking at assessments, okay, these are, let's say this is an established patient, and now they look like they're distended. All right, let's figure out what's distended and why. Right? Are they parking fluid like ascites, like an alcohol? We think of beer belly. Well, it's not necessarily fat. It can be fluid accumulation or fluid mismanagement. If somebody is girthy, is that fluid? Is that adipose tissue? What the heck is it? Okay, so what's their kidney status? We start asking the renal questions. Um, in some cases, if you're doing healthcare in austere locations, that's one of the first things they're going to do. It's not that everybody has a 12 lead or has access to a 12 lead for cardiac functioning. They're going to ask you if you've been peeing and how much so. Okay. When we look at edema, hopefully you know how to assess edema and what edema means. It means you're mismanaging fluid. Okay. And we're typically looking at cardiac dysfunction, or we're looking at renal dysfunction. See, neurologic assessment can be 101 plus things. Okay, doing the cranial nerves, yes. Okay, the push, pull, squeeze, all that stuff, yes. The mental status exam, we're doing that all day, all the time with our patients. Speech and language ability, not just can they pronounce words? Are they can they follow instructions? Okay. If I tell you touch your nose and then touch your elbow, okay, with your left index finger, touch your elbow and then touch your nose. Okay, why do I do that? Does your right elbow touch your nose? Because I want to see if you can follow a two-step process. Okay, some of the questions that I need you to remember these 3 words. Okay, and I'm gonna have you call them back to me in just a minute. And we go on and we give them those 3 words. They aren't supposed to have anything to do with each other. And then we come back and ask them 5 minutes later, what were those 3 words again? Oh, it was cuckoo clock, it was fire truck, and it was Rembrandt. Those are the 3 words that you wanted me to remember. All right, cool. Okay, why those words? I don't know. Why not? Okay, but I'm testing short-term memory. Okay, if I do serial 7 with somebody and have them count backwards from 100 by 7, what am I doing? I'm engaging the cognitive functions. Okay, seeing about the cognitive functions of their brain. I'm getting them to do computational skills. If I just assess cranial nerves, I've got the eyes, I've got the ears, I've got all of those things. Okay, but am I really doing it justice? Okay, do you have this card in your truck? I never had it in my truck. Maybe I just don't know. When you assess this patient, even doing the cranial nerves, are you doing it right or are you doing it wrong? Okay, I need you to smile for me. Okay, puff out your cheeks, do this, do that. Squeeze my hands. Okay, press against. Close your eyes and hold your arms out. We're doing stroke screens like all the time. But when's the last time you had somebody clench up their jaws and then ascertain whether there was equal muscle contraction on both sides? Okay? All right, close your eyes and tell me which side of my touch is light touch, heavy touch on the right and the left, looking at the different components. Okay, so now not only do you have the muscular aspect of the trigeminal, you've got the sensory aspect. Okay, close your eyes, open your eyes, raise your eyebrows, puff out your cheeks, stick out your tongue, say ah. Okay, with that cranial nerve check here, what should happen to this back here? It should not move or deviate to the right or left. It should just go up and down, correct? And if it went to the right or left, what might that indicate? A deficit, okay? So muscular contraction should be equal on both sides of that. So if it's not, then it's going to deviate to the strong side, which means I got a deficit on that side. I need to look at and watch for any sort of difficulty swallowing, difficulty speaking, increased aspirational risk, neurological defects. Okay. So, 12th cranial nerve, have the patient stick out their tongue. All right, we're used to doing this. Stick out your tongue for me, and what are we looking for? We're looking for deviation. Again, any sort of deviation to this side would have that side of the tongue having a lisp to it. Okay, not lisp as in lisp, but lisp as in deficit. Okay, this is hanging down a little bit further than that. But you'd also probably notice some facial drooping. You might notice that eye drooping a little bit. Okay, the fact that it looks like they had Botox or numbing agents over here, and this one is more responsive. As we are going through motor pathway, we're used to doing this stuff. Okay, we're not grabbing safety pins and stabbing people in the feet, but what are we doing? Okay, which one can you feel? Which toe? All right. Now, what we could be doing is the discern between light touch, heavy touch, sharp, and dull. Okay, so if you just take an ink pen and use the top part that is a little softer, a little more rounded, and rubbing that on your hand versus the part where the pen actually comes out and rubbing that, both of them, they feel different. Okay, the one is soft, one is pointed. Getting them to tell you if they can sensorially distinguish between those two things. Okay, it's a good test. DTRs, deep tendon reflexes. Sometimes you need to be able to test these, and doing those is kind of simple. If you have the right equipment, it's really simple. If you don't have the right equipment, you can improvise it for most of it. Okay? And it does tell you about neurologic status. But look at that last thing, the electrolyte status as well. Okay? If I'm looking at the muscular response, what electrolytes are really kind of important for skeletal muscle response? I'm looking at calcium levels. So if I have somebody, I don't know, hypothetically say, a female who has issues with their DTRs and she has full body swelling and pregnancy-induced hypertension and all these things, I think, oh God, this big swole up individual is the poster child for potentially having a seizure. Yeah. Well, a DTR check is also going to show you that her calcium levels have been affected. And guess what else is affected in there? Well, what do we throw at people who have, I don't know, frantic seizures? Magnesium. Okay? So, if you know how to use the DTR check, you can see that this patient might be kind of inching toward that before they go into a seizure state. All right. Patellar reflex that's accomplished with patient sitting, legs hanging, and knees flexed. Okay. Now, here's the thing. If they tighten up their quads, you're not going to get a true representation of this. Okay, bicep tendon. Okay, this one it kind of hurts. Okay, because you're striking your thumb with a reflex hammer, and that's if you have it. And if you're using your stethoscope to strike your thumb, it really hurts because you're hitting yourself on a nail bed with that. So, yeah. Brachioradialis reflex and difficult to elicit, strike 2 inches above the wrist. Okay, you're supporting their arm and you have their arm like this. You're going to use the reflex hammer here, and you're going to see a fire up that way. Right now, can you do all of this stuff? Yeah. Do you need to do all this stuff? No. But if the patient has a complaint that would warrant you checking all this stuff, then yeah, you would. Okay. Again, this isn't about 911 transport per se. This is about patient assessment and outside the hospital sort of setting, something that a physician may want you to check, in the telehealth or that mobile integrated healthcare setting. Okay. So, as we're looking at abdomen and things like that, why would we care about abdominal fluid accumulation? Well, it tells us about renal cardiovascular status. Why would we care potentially about surgical scarring, new or old, in our patients' complaint of issues? Okay. Well, scar tissue causes adhesion. Adhesion causes dysfunction, increases the chance of, um, slowed motility or scar accumulation to the point where you just have a section of bowel that no longer freaking works and you don't have peristalsis. Okay? So all of this stuff means something, but you typically have to take it 2 or 3 steps. Okay? Now, as you can do this, these forms of assessment, all this palpation, light and deep, you got to know why you're doing those sorts of assessments. Okay. Now, this looks kind of wrong, but list abdominal reflex by stroking the abdomen in all 4 quadrants. Okay. What's going to happen? Okay. Even if you're not ticklish, chances are people are going to tense that musculature up. Okay. If they can't, if they don't, if sensory input is limited, okay, that's the kind of stuff that we're looking for. Now, anyway, when it comes to musculoskeletal stuff, we're looking for unity, okay, as in I want a unified body, which means I want a symmetrical body. I want your right side to be approximately the exact same size as your left when it comes to pieces, parts, and joints. Now, why approximately the same size? Because if you're right hand dominant, right arm dominant, whatever, Left arm dominant, your dominant side is going to be slightly larger, but that's usually just a muscle mass, not in joint. If it is a problem in the joint, then you're typically looking at an arthritic sort of change. Now, let's explore that. All right, so looking at joint symmetry and range of motion, is it passive range of motion that they're having a problem, or is it when they move active range of motion that they're having a problem? Okay, do I have redness and edema? Both of those are inflammatory responses. It can be cellulitis, it can be, arthritic changes, it can be bursitis, it can be a whole bunch of different things. And now let's see what part is bothering them. Okay, certain places on the elbow tells me what's going on. Okay, that's tennis elbow or whatever. Okay, certain areas or manifestations on the exam of the shoulder tells me that's more or less likely of being a rotator cuff tear. Okay, or a torn bicep tendon or whatever. Okay, so anatomy and physiology is your friend. When I examine somebody's knee, okay, they've got a swollen knee, they've got popping, they got clicking. Okay, let's do the drawer test. Let's see if you've got any sort of lateral stability problems, so I can tell whether you have meniscus issues or whether you got an ACL or PCL. Now, how much resistance can you, not resistance, but how much flexion and extension can you do? When do you have that problem? What does it feel like? Does it ever get weak? If you know the right assessment techniques and the right questions, we can get fairly close to what's going on with that patient, and they haven't had a soft tissue study yet. Okay, they haven't had a CT, they haven't had an MRI, but if you were face to face, so to speak, virtually with a doc, and you were doing these tests, now you've got supportive documentation or supportive assessment findings that doc could then telehealth and send that patient to an ortho or start the ball rolling to get those soft tissue studies. Okay. So anyway, let's talk about that. You know about SOAP and how to write down your information. Now, that's it on advancing assessment. Again, I'm trying to give you credit for knowing how to assess and not insult anybody's intelligence. So let's see. Oops. Yep. So anyway, there's just a very small presentation that I'm going to do a different recording on about mental status exams, and that'll be it for the week as far as listening to me. All right, hope you guys have a great day, and